Hello, and welcome to the Alabama Public Health Training Network. Thank you for joining us today for Part 2 of our program, Tuberculosis 101 for Disease Control Staff. In Part 1 from last week, we focused on the basic principles of TB, including transmission and pathogenesis, as well as differentiating between tuberculosis disease and TB infection. Now we will discuss the initiation and management of a TB case investigation, including special considerations for congregate settings. If you have questions about anything being discussed, please call or email during our broadcast. The phone number and email address are on your screen now and will appear again later in the program. Also, the handouts, the sign-in sheets, and evaluation are all available online. You will need to register for this program in order to access those materials. Continuing education credits have been approved for nurses and social workers for today's program. In order to receive credit for the training, you must watch the entire program, then complete and return the sign-in sheet and evaluation. While content may continue to be relevant, CE credits will be only awarded for 1 year and will expire on December 31st, 2015. I'm Pam Barrett, Director of the Division of TB Control, and with me today is Carl Evans, Area 2 Tuberculosis Program Manager. Also, we have Dr. Karen Landers, Assistant State Health Officer and Pediatric TB and Immunization Consultant. Now we'll turn the program over to Carl. Good morning, Carl.
Good morning, Pam. Thank you for joining us this morning. I'd like to thank Pam for her invitation of asking me to do this, by the way. Today, we're going to discuss the transmission and the investigation part of a contact investigation channel towards tuberculosis. But there are some other programs out there that can benefit from the investigation process. Those that can investigate other diseases such as STD and uses by social workers. So we're going to get started. I'm going to refresh some things that may be from the last presentation, just in case you did not join us then. I'm just going to talk about the transmission of tuberculosis. Tuberculosis is caused by Mycobacterium tuberculosis, and we do know that it's only transmissible from person to person. You cannot acquire TB from a person home just because and take it on home with you from your clothes. You must breathe this germ in. And this disease is pretty hard to acquire because it requires you to spend a significant amount of time with these individuals. The transmission of tuberculosis, when a person with infection TB disease coughs, sneezes, speaks, this droplet nuclei are expelled. These are small little microns in diameter. They can remain suspended for several hours, and that is contingent upon the temperature also in the room. If another person inhales these droplets, transmission can occur. Now, a person may contact pulmonary tuberculosis from inhaling these droplets, and you'll see that once that germ is inhaled into the body, your immune system goes out and tries to send its fighter to make sure that this germ does not grow. And while healing the body, sometimes you experience, or on the film, you see areas of granulomas in the lung tissue. Things to know prior to starting an investigation. As with any investigation, we're going to talk about anatomical sites of disease, sputum bacteriology, radiographic findings. So each of these points are very important in any investigation. You must know what you're working with in the sense of where the disease is actually taking place in the body. So is it a pulmonary case or is it an extrapulmonary case? That is very important so that you don't overtest. One of the challenges of investigations is overtesting. We don't want to do any more than what we have to do because of cost analysis, but we don't want to miss anyone. However, we don't want to continue to test if we don't have to test someone if they're not pulmonary outside of the first layer of concentric circle, which we'll get to later on. So let's take a look at some of the locations in the body, anatomical site of this disease. Here we see a cervical node, lymph node TB progressing to an abscess. Now this type of infection, of disease process, has occurred in the lymphatic system, but it was inhaled. This germ was still inhaled through the respiratory process. That's how the germ enters the body, by breathing this germ in. It's not surface contact. It's actually breathing this germ in into the body, and it travels throughout the lymphatic system of the blood and gets in the lymphatic system, and this has caused the infection of the abscess. Now, what problem that we experience with an abscess is that most of our patients, if we have this, they believe that once this is cut out, that they do not have to go through the treatment process, but that's not true. Even if that is excised or cut out, that germ is still circulating in the body, and so we must go through the same amount of time of treatment. So that's one of the difficult processes of counseling a patient, saying, well, the doctor removed this node, so why do I have to go 6 or 9 months of treatment when he cut it out? But we want to make sure we get all that germ, and they still have to be treated for the same length of time, depending upon the physician recommendation. Here we have the physical appearance of Pott's disease. Pott's disease is tuberculosis of the spinal column. Now this is also extrapulmonary, where if we were doing a contact investigation on this person, it more than likely can be confined to the household, and then after that we will probably not test beyond that, because unless it's a pulmonary process also occurring, we probably not end up doing any more than we have to, just testing the family, trying to find out where this person may have acquired this from, close contact. So here you can see the devastating effect of tuberculosis on the body. Here you have the compression of the spinal column, where you have the protrusion of the spine. In this individual here, you see the bowing of the spinal column, and that's. But this is treatable and curable. More than likely, a rod would be inserted into this person back and to help assist with the straightening process. So we looked at the anatomical side of this disease. Now let's look at the sputum bacteriology. One way to measure how contagious a person is by acquiring a sample of their cough. Many times we see where the simple thing to do is just to collect a person's cough if they're symptomatic. Occasionally we'll find people doing bronchoscopies and things like that, and the person actually still have a cough, but they want to go into the lungs and remove a bronch washing or bronch tissue sample or biopsy. But if the person is able to produce a sputum, a cough sample, let's try to get that initially so we can determine how the level of infectiousness is by sending that to the lab and getting the results of that test. If we know that that person is sputum smear positive, then we believe that that person has that ability to cough this germ out in the air. As with any investigation, even if the sputum are negative and culture positive, we still believe that person has the ability to transmit that germ. So we cannot fully rely upon the results of the sputum to tell us if that person is spewing out germs. Just because you get a smear negative result, we still, once you get that culture report and it says that person from that same sample culture positive, then we still look at that investigation. You still must do an investigation on that individual, because it's still there. It's still that person, no matter what level, that person still have that ability to transmit, and someone, especially children, are our priorities. And when you're looking at a contact investigation, those less than 5 years of age. Here we have a chest X-ray, radiographic findings. Here we're trying to paint this picture. We're trying to get everything to the physician, our TB physician, to make his diagnosis. We put a puzzle together so we can acquire the sputum bacteriology report, the symptoms assessment, the TST or the T-spot testing results, and the chest X-ray. We can present this to our TB physician. And so that person will have a better understanding where the disease is taking place and what's the actual physical appearance of that X-ray. Tells them a lot more about the process. Okay? So, because TB can be, this X-ray here shows pulmonary process. However, TB, again, can be anywhere in the body. So if it's pleural, yes, it looks like it's in the lung, but it's outside of the lungs if it's in the pleural space. But this actually involved a person who has a pulmonary process taking place. Tuberculosis most causes a chronic pneumonia that leads to wasting similar to cancer. So one of the symptoms of TB is unexplained loss of weight, loss of appetite. And I'm quite sure this was covered by Dr. Landers on the last session, but this is just a refresher for those individuals that are joining us today and had not had the opportunity to see that presentation. So one of the symptoms, again, is unexplained loss of weight, loss of appetite, fever, chest pains, unknown new chest pains, something that's has not been occurring, fatigue, increased fatigue, okay, night sweating, hoarseness of the voice, and a productive cough can also are some of the symptoms of active TB or a person going through it. And it can affect any organ system, bone marrow, lymphatics, lymph nodes. So we saw some pictures of the lymph node, and we saw some of the bone. Common symptoms, again, I just stated those. Hemoptysis, coughing up blood. So if a person presents and one of the symptoms is hemoptysis, then we need to think TB. That's on our slogan, think TB. Because at this time of the year, a person can present with the loss of appetite, loss of weight, or a cough, and that really don't bring any attention to TB. But hemoptysis and night sweats, those are some of the key points to think TB. And we hope that you're doing that. So let's look at the probability TB will be transmitted. So we need to know, why do some people acquire TB and some don't? I mean, coming from a case exposure. So the probability of TB being transmitted has different variables. No variables that you need to know. This is somewhat what we call our pre-investigative homework. So the probability TB will be transmitted involves the infections of the person. So if you're dealing with a person who has a smear negative cough sample and they're asymptomatic, then not that you're delaying the process of investigation, but you need to gather some more information before you run out and start knocking on doors. Okay? Environment where the exposure occurred. We know that close environment, meaning that a house or even in a home, we look at different square footage of a home. We look at the difference between someone living in a 450 square foot apartment versus someone living in a 4,000 square foot home. So the environment where the exposure occurred are sometimes depending upon if that transmission took place. Duration of exposure. Now this brings a lot of challenges in question. They want to know, how much time must I spend around a person before, how much germ can I inhale, or how long can I be around this person? And this coming from any program, because if not only do TB have to go out into that same home, but you might have home health nurses that also visit that home. But we know that if you're wearing your protective N95 mask, again, you cannot just acquire TB from this germ getting on your clothes and you taking it on to your home and your children. So those are some of the concerns which we are presented weekly, or when we have our student nurses come to visit with us in our clinic. They're sometimes terrified to come into the clinic knowing that I may encounter someone with TB and I can take this home to my children, but that is not true. That child itself must come in contact with an active case and not from a third party. So virulence of this organism. There are some germs out there that are very tough and strong. Some bugs are very aggressive, meaning that yes, they can be killed, however it may take a longer duration of treatment. So virulence of the organism. We can acquire this information most of the time in TB through looking at the genotyping. Genotyping sometimes tell us if from other cases that this germ that we're messing with or dealing with is going to be aggressive or extended duration of time, and that's something that a good TB investigator, TB nurse will look at. So how do we decide to initiate a TB contact investigation? So from your screen, you'll see that the site of disease. Again, knowing if it's a pulmonary versus pulmonary site, and from there you just follow the arrows down from left to right is a pulmonary laryngeal. We know laryngeal is highly contagious because that person doesn't have to cough this germ out. They can just whisper, talk this germ out into the air, and these droplets are suspended, and we instantly come along. I tell the student nurses all the time that if you get a person very hoarse in the hospital, and the first thing they want to do is go over to the bedside and put their ear down there trying to hear it. But if that person has pulmonary TB or is suspected of having pulmonary TB, and that's a risk if you're not wearing your N95 or your minimal N95 respirator. So by following this algorithm, you can determine if this is someone that you want to pursue a direct contact investigation on. Okay. So what is a contact investigation? A contact investigation is a procedure of identifying people who are exposed to someone with infectious TB. Okay? So by looking at that sentence, you have to have someone who's infected and someone who is able to expel this germ out. But a lot of your information is not really available to you in the initial part of an investigation. So all investigations start out, pulmonary or extrapulmonary, with a contact investigation or a interview or a question session. Evaluating these people for latent TB infection and TB disease, determining, okay, this person has a positive T-spot, a positive TST, abnormal chest x-ray versus a normal chest x-ray. Determine how far, again, how are you going to proceed. Providing appropriate treatment for those with LTBI, latent TB infection, and those with TB disease. Okay. So let's look at some terms. A contact. A contact is an individual who is at risk for TB infection or TB disease due to exposure from someone with infectious TB disease. Okay? So tuberculosis itself is a term that we throw around. Lay people may not understand, and it's not saying just lay people, people outside TB. We use terms pretty lazy sometimes when we say TB. Oh, that person being treated for TB, or I'm in the clinic because I'm taking TB meds, or I have TB. But that person may not have active TB. That person may have latent TB infection. So knowing the difference between latent TB infection will sometimes relieve you if you're someone who has reservations with dealing or treating or counseling someone who's on medication for TB. So many times we do see where a person is just taking latent TB infection, but they panic. The healthcare worker or social worker, they want to know, is this person contagious? Do they need to come into the clinic? Well, this is our job as a TB person or a TB manager, a TB nurse, a DIS, disease investigator, or public health advisor, to let the staff know when that person is presented that there are no define exactly what they have. You're someone with the germ in your body that cannot be passed out to other people. And by taking this medication, we're reducing your risk that you're able to develop active TB. That's latent TB infection. Where someone who is taking multiple drug treatment and diagnosed with TB, then one way to find out that person ever been treated, we always ask, did someone watch you take your pills? Did someone bring those pills to you, to your home, to your job, to wherever, and did they observe you swallow those pills? Where in the state of Alabama, we have directly observed therapy for those individuals. So that's a good way to ask that person. Well, this person that may be presented may be a child, have taken this medicine as a child, and their mother or grandmother or somebody may have to tell them, well, you had TB. Well, you have to find out exactly, did they actually have TB or did they have TB infection? Okay? So index patient or case. This individual has been confirmed or suspected of having TB, reported to the health department. Now, this index case is who started it. It's not always your source patient, but this is the person who started the investigation, index. That's the pinnacle, that person who's sitting at the top. And everything starts from that individual. Now, that may end up being your source. But one thing you have to realize in a contact investigation, that there's always a source and there's always spreads. Okay? Because somebody had to give it to that individual, even though that individual may not ever find out or ever know who passed that germ to them. But for every case, there is a source and there is a spread. So the index patient is not always a source patient, but if that is, there's another source patient out there that they may not even know they have. So continue with terms. We look at high-risk contacts. Those are high-priority contacts, meaning contacts who are evaluated without delay. And who are these individuals? Who are these people? Those most likely to be infected includes close contacts to be highly contagious case. Most of us spend most of our time in any investigation. You spend most of your time in two locations, sometimes 3, but the priority will be in the home. We spend 8 to 10 hours at most in our home every day. If we have someone sharing that time, that space and time with us, those are the individuals that we want to concentrate on. And there, it may expand outward, but for the most part, the center people in any investigation are those close contacts if it occurs in the home or the location that these person visits. Outside the home, we look at work, school, or whatever the secondary place this person spend their time, adult daycare or wherever they may go. These are risk factors for progression to disease once infected. So let's look at source case. We said the source case is the person who has been confirmed infectious with having pulmonary laryngeal TB, who is responsible for transmitting TB to others. Okay, that is the individual that when we find case A, and case A is our index, and we start asking a question in that index case, especially if this is a child, you know, we have to look at who transmitted this germ to this child. Anyone under 4 or 5 years old has very limited places they have ever visited or been, because the center people in their lives are their mother, or their parents or grandparents or babysitter. So it's not like you're chasing 50 people, hopefully not. But if you start working with the parents, the grandparents, the daycare worker, you'll eventually find that source case. Okay? The source patient is not necessarily the index patient. We stated that before. And if that happened to be, great, but it doesn't necessarily have to mean that that is the person that started everything. So why is a contact investigation important? It's very important because we must find out, again, who passed this germ, knowingly or not knowingly. So there are people who are sick and may not know they have active TB, but they continue to go on their daily lives as if nothing is wrong with them. You know, they might have this significant cough for a long duration of time and just say, well, I'll just take this cough medicine and I know I'll get better. And that, as that person going through their daily lives, they're continuously transmitting this germ, going to work, going to church, going to different locations, and they're continuing to have the ability to pass this germ out. So we want to find those individuals and give them opportunity to be tested. So we're the legs. If the case themselves do not wish to provide, do not wish to inform those individuals, we are the legs in the vehicle to go out and to inform in a confidential manner. Hey, someone provided you my name, or someone provided you with your name, and they cared enough about you that they wish for you to be tested for tuberculosis, and we'll then let them know what the testing procedure is. Okay, so is it going to be with the man-tube method, or is it going to be with the quantiferon or the blood or T-spot method? So we want to let that person know. So we want to know who has the TB disease so they can be given treatment and further transmission to stop. We want to intervene in the spread of disease. That's our main goal, is to intervene. We want to cut down the next case, the secondary case. We don't want this thing to keep going and going and going like the ever-ready bunny. We want to stop it where we can control it, and also we want to find those individuals and go through the process, test them, and if they're positive, provide that chest x-ray or give them the means of getting that chest x-ray. And we want to treat. Not only do we want to test, but we want to give them the opportunity to be treated. Because if that germ is left untreated, then we know that can be our case down the line. So why is a contact investigation important? Another point is they're at high risk of developing disease, and like I stated before, and they may need treatment for LTBI until it becomes clear whether they have TB infection. Okay, So a lot of our suspects starts out with multiple drugs, and once we figure out that they're not considered contagious or they're cleared from having active TB, then we might, if they have a positive skin test, then we'll go ahead and transition them to a LTBI treatment. But initially, some of our patients starts out as suspects, ruled out, and then they're given LTBI treatment. Okay. So when is a contact investigation done? And generally, a contact investigation should be done whenever a patient is found to have or is suspected of having infectious TB disease. So a little tidbit. In this slide here, we also go back and look at pulmonary versus extrapulmonary. We start out as if everyone is contagious. Okay, that is a key point, because we don't want to just say this person has this person lab report stated that this germ was isolated to TB of the knee. So they did a biopsy of the knee, and that person had surgery, cleaned out, but we still have to think about this germ is circulating in the body. Could it be in dual locations or multiple locations? So we always think that this germ, being in a respiratory process, came into the body, is still lodged in the lungs. And through the blood circulation or circulatory system, travel out through a weak part of the body. So a contact investigation should be done when TB is confirmed or there's a highly suspicious clinical case. So now we say extrapulmonary, pulmonary, or clinical. So if they are symptomatic, okay, there's a reason why they're symptomatic, okay, and we might not find out exactly through the testing procedure of sputum or biopsy, but that person is exhibiting those symptoms consistent with TB. There's a time frame where that physician can say, let's start them on TB meds and see if they get better. And after a certain point of time, if they're improved, that diagnosis can be made by that clinical provider that, hey, yes, I believe that was really TB, so we'll continue with that treatment. And that's when you go ahead and count that person as a clinical or provider diagnosis. Prioritizing contact investigations. Who was exposed to the TB patient that is most likely to be infectious, and who is a higher risk for TB infection or disease? So we're going to get to those individuals who are in that, what we call, when we peel back the layers of the onion. In the center part of that onion, we have the household contacts, and we'll look at that in the concentric circle approach. How quickly should a contact investigation be carried out? Now, according to your state SOP, again, CDC gives their recommendation. You can find a lot of this material in CDC. However, no more than 3 working days after the case is reported to the health department. So there's a time frame, meaning things can move quickly, depending upon your staff, depending upon the resources available to you. But we say no more than 3 working days after the case is reported to the health department. Again, we say case, but it could be a suspect. Okay? Close contacts should be examined within 7 working days after the index case has been diagnosed. So we move in 3 days on the information that comes to us that, hey, there's a person in the a hospital, or there's a person that's been isolated there, and we believe that person has TB. That worker will make their way to the to the hospital or wherever they are in the home, and we'll start doing the contact the interview process there. And after we acquire what we need from that individual, we have 7 days to get the contacts, the close contacts, worked, meaning test it and hopefully evaluate it by chest x-ray and present it to the TB physician within those 7 working days. So who's ultimately responsible for a contact investigation? The health department is legally responsible for ensuring that a complete contact investigation is done for the TB case reported in its area. That's one of the reasons why private physicians do not manage TB cases. The health department manages all TB cases, and that is our duty is to manage these cases by the protocol that's set forth by ADPH. Again, if you're watching from other states, you have to look at your state protocol. But ultimately, the health department is given legal responsibility to ensure that a complete investigation is done, and it's up to that program manager or that nurse coordinator to ensure that the workers are completing these things by observing and keeping a constant observance on their epi work. Because just because you believe that person has started that investigation, you need to just double make sure that that is taking place. Because as time goes by, people can be missed. People travel. People get away from that individual fast. And one thing about TB, tuberculosis is a disease that still has a lot of stigma related to it. And being that it does, people lock down information. So the faster you get out there, the faster you'll find things where people cannot conceal. So this includes identifying and evaluating contacts, treating any contacts found to have TB disease, offering TB treatment, offering treatment for LTBI infected contacts, monitoring adherence to prescribed regimen, ensuring systems are in place to ensure SS completion of treatment. Now with LTBI means that, okay, I had a positive skin test, my x-ray has been determined to be normal, I'm not symptomatic, and I'm someone who just believes I have the germ in my body and cannot transmit it out. We've offered medication, but that person doesn't necessarily have to accept our offer. We highly coach that person to say, hey, look at the benefits of being treated. But if that individual does not wish to be treated, then we document and move on. But we also have to realize if this is a close contact, we don't want to give up so fast. Because those individuals have that duration of time spent with, and depending on if this virulence of the germ, this may be our case within the first 5 years from now. This person have a high risk of breaking down to be our secondary case from the primary case. So we need to monitor the prescribed regimen, making sure that if someone is recommended treatment for TB disease or latent TB infection, that it complies with our protocol on medication, making sure that if it's written from a private physician, that medication dosage align with what ADPH guidelines are. If they're not, we present to our TB physician and we correct it, or we let our physician consult with the physician who wrote that prescription. As a manager, I can go to that individual, but I found that when you're working with other physicians outside of the health department, it's best to see if the TB physician will consult with that individual, and they'll haggle out a treatment. But then again, the health department is ultimately responsible for treatment. So if our TB physician writes the order, that's the one we'll follow. Okay. So let's look at the concentric circle approach. Here we have a basic outline. Now this concentric circle, if you research this or you Google or go on the web, you'll find a lot of concentric circle approaches. But this one here looks at specific for contacts investigation of TB. But you can use this for other programs other than TB, because we look at the center. The center concentrates on the home setting. Again, we spend a significant amount of our time in the home. So if there was a case, we start in the home. We test those individuals. We screen those individuals. And then we get them the proper treatment. The second layer is, where did that person spend the other part of their time? Work, school? That's what we normally find. After that, leisure setting. Okay. Sometimes leisure setting will open those doors to people in your secondary cases and you never know they're linked. That could be their cart buddies, or they could be going to a location where activities take place and they don't know each other. I mean, that has happened before. No one wants to name that little place everybody go, and well, I just see that guy, but I don't know his name. Well, you might have to visit that location and find out, okay, what time did you go there? And when you go, you might say, well, you might have come in contact with an individual that has TB, and so I'm offering you a TB test. Okay. So the concentric circle is a method of classifying and screening contacts in order of intensity of exposure and risk of being infected. Contacts with the most exposure or highest risk of infection are screened first. Okay, so we don't want to go from the leisure in, we want to go from the home out. Okay. Steps in the contact investigation. In general, contact investigations follow a process that include the medical review. So this is what most investigators have to contend with. Yes, we get that report that there's someone in the hospital suspected of having TB, or there's a paperwork comes in, this person has been confirmed by laboratory bacteriology that the person has active TB. So what do an investigator actually now step up and say, okay, what is my normal procedures? First, we need to have a medical review. Find out more about that individual. With the computer at your readily available desk here, you can start Googling people. You can look on the web. You can start finding out more about an individual by just researching. Okay, see if they have a medical chart in the clinics. Then you call the infection control nurse, and you start getting the H&P or the demographics, and you're putting this now again. You're putting everything together. Okay, before I even make my visit to the hospital, I want to know, who am I really dealing with before I go up there? Is this someone that had a problem in the past? Does this person have a rap sheet that could reach to the floor? I mean, you have to find out who this person is. I mean, you don't have to go to the 10th degree, but you want to know at least something about that person before you go in there and say, "Hi, my name is Carl." Okay? So when we go to that individual, we need to start with the patient interview. The patient interview, as an investigator or as a public health worker or STD worker, whoever you are, you want to have your interview set up in a way that you know what questions you want to ask before you get there. You want to go in there and start fumbling around. You want to have it where I want to know his name, his nickname. I want to know where his address. I want to know how long he lived at that address. I want to know what transportation he has, what the color of his transportation. I want to know where he's worked, what his out. In that interview, you want to know everything and have it in an orderly process, so that you try not to, because this might be your only interview you might get. Okay, this might be a homeless guy who, once he's released, you may not be able to find him. So you continue to have it there where, hey, I want to ask everything and not try to miss anything. So after the interview, we have the field investigation. So you're saying, well, I interviewed this guy, he gave me these names, so I need to go out and find him. Well, that is true in a way, but first you need to know more about the patient. The field investigation is a second part of the patient interview. So while the patient may be still in the hospital or out, you want to go by that home. You want to check out, where is he living? Is this information truthful that he just gave me? You want to know if that person is in that 400 square foot apartment versus that 4,000 square foot house. You want to know if that is the home that all the kids come over and play. They might be swing sets, bicycles, skateboards, okay? And that person only gave you one name, my wife. You know, you want to know all that information. So the field investigation is the third part of that. Risk assessment. How much of this germ is coming out of this guy or woman? So here we have the medical. Again, we're going to review these individually. The medical review. The first step in a contact investigation is review the TB patient medical records and ask for clinical information. The nurse on the floor is a very important person. Okay, when you go up on the floor and you want to know, okay, is Mr. So-and-so still in room whatever? Yes, he is. When you get on the floor, ask the nurse. Stop by the nurse's desk. Who's been visiting this guy? And sometimes they'll tell you, oh, everybody from his church been here Sunday. Everyone, his wife and 3 children came visiting last night. When you get in the room, he says, nobody ever comes up here. So that nurse is your eyes while you're not there. Okay? And sometimes even the infection control nurse, they might not even know that that person is on the floor being treated. But you ask for that information. You ask for medical records. Now, you might not get all his medical records, being that he's still in the hospital, but you get as much as you can from the infection control person. The interview. This information includes the disease characteristics, onset of illness. Again, this is what you can prefab this information. If you're not so a veteran interviewer, you can prefab your interview sheets. But if you're a veteran, you have this in your mind, you know what you want to ask, that's fine. But if you're not experienced, you want to have all these things written down so that when you go in there, you obtain as much information you can. And onset of illness is characterized as when did this person first start noticing symptoms. Okay? So TB is not a disease that you acquire today and symptoms occur tomorrow. This germ has been inhaled and was in the body for at least a period of time before you even notice any symptoms. And in that time process, you may have been able to transmit this germ without knowing that you ever was passing out anything. So we routinely go back 3 months from the onset of noticing symptoms. So as an investigator, if a person presented today and said, well, I noticed that on December the 1st, we go back 3 months from December the 1st as their onset of illness, illness time. So continuing, current medical factors, initiation of effective treatment. We want to know when they began this treatment process, because that's important, because you have different regimens of treatment for TB cases. You have the first 8 weeks of TB meds, you have the first 2 weeks daily, and 6 weeks of twice weekly. So you can look at CDC guidelines, they'll tell you the 3 different versions of treatment and the time frame for that medication and when medicine should be stopped. The patient interview. It is one of the most critical parts of the contact investigation. It is essential that that time is spent wisely interviewing that patient. Because the healthcare worker who interviews the patient serves as the main link between the health department and the contacts. Because if the patient themselves conceals, you have to continue to go and build a rapport with that individual to say, look, somebody gave it to you, but you can stop this disease. You can stop this process. Let us be your voice in saying, hey, give them an opportunity to be tested at least. Okay? Just don't give up. Because I know there are some patients that you want to just throw your hands up and say, oh, I'll be glad when they're over with. However, look at the little ones and the wives and whoever else, because being that link, we play a very essential part of that, and I just ask that you don't give up, please. Interviewing the patient. In addition to setting the direction for contact investigation, the first interview provides opportunity for the patient to acquire information regarding TB and its control for the public health worker to learn to provide treatment and specific care for the patient, just like I stated before. We talked about the period of infectiousness. This is the period where during a person with TB is capable of transmitting TB. Determine the period of infection can help focus on contact investigation of those persons exposed while patient was infectious. I heard a physician say the most day of infectiousness of a patient is the day before they started medication. And that is true. So while they're on medicine, we know the medicine will work unless they have a resistant bug. Our job is to find those individuals prior to medication. And it's not simple. It's simple, but you have to be determined that you're in this. If you're doing this kind of work, you should be able to say, hey, this is my job. This is something I care enough about that I don't want next year to have more cases than I had this year. And again, you might not have the ability to stop anything, but again, that's a goal you should have. Let me do everything I can to make sure that this is not a secondary case. So a period of infectiousness. Estimating the period of infection should be done by clinical supervisory staff. So here again, the program manager sit down with the worker, and we try to figure out when this person became infectious, and we determine how large this investigation is going to be. Completing the interview. Before completing the interview, the healthcare worker and the patient should decide on who will notify the contacts. Again, we are their mouth, we are their vehicle, we are their legs. Again, stigma is related to TB. A lot of people do not wish to identify themselves as being, I have TB. Go tell my coworkers that I have TB. No, that's something they do not want to do. So here we are. We go out and, again, like I stated, someone provided or cared enough about you to want you to have this information. And now is our opportunity to say, hey, you can come down to the health department, or we can come to you and provide testing. Okay? Some patients prefer to notify their own. We find this to be their family or close friends. But outside of that, that doesn't really happen where they just go and tell everybody, you know, the church. And we're going to get to that second part of the presentation, special consideration here. So investigation. We want to build a rapport. We want to exchange information. That information exchange could be, hey, depending upon the age of the person, we're not going to send you to a sanatorium. We'll treat you in your home. You don't have to do all these things that used to, depending on the age of the person. You know, you have an 85-year-old man, he remembers those days. So that information needs to be exchanged. There's nothing, we're not going to send you away. You can stay at your home, we'll bring you your medicine, you don't have to drive. You know, we don't want that 85-year-old man, if he have a problem driving, to be driving. We look at the transmission setting. Site of transmission, list of contacts, closure. And let them know there could possibly be follow-up interviews. Okay? Steps in the contact investigation. Decision about priority contacts. Evaluation of contacts. Treatment follow-up. Decision on whether to expand testing. Again, over-testing is a big problem. And so before you start looking at expanding testing, you may want to get with your supervisor or a senior person and say, look at this. I went through my concentric circle approach and I looked at the positivity rate and I'm still here. So, yes, let's go ahead and expand testing for this next subgroup. But be aware that sometimes over-testing will not yield any more than what you already have. And it's costly to the organization by over-testing. Field investigation. Visiting the patient home and shelter, workplace, and other places where the patient said he or she spent time while infectious. And this may involve in-state or out-of-state. So you may have to send interjurisdictional letters out-of-state. And hopefully that work on the other end, care enough the same way that you care, will do the legwork and go out and try to test those individuals. Visiting index patient residence is especially helpful. Now be in mind that field safety come into play. We'll talk about field safety also. Doing your homework will tell you, is it safe to go out into someone's residence or that homeless camp. But it's very helpful in finding children, no matter when you're going out to that residence. Again, that might be the home where every child in the neighborhood plays. But that person tells you, hey, Carl, I tell you what, I'll be in the clinic every day at 8 o'clock. You don't have to worry about me. And he could be telling the truth. He can do that. But that does not give you the deferment of saying, well, Mr. Smith, he's okay. He's going to come in. Well, you're doing only one part. You're DOTing them, but you're not trying to find the contacts. So your job is to go out and do a drive-by, do a home visit, unannounced home visit. And there you can find out, okay, the environmental issues, how the house is ventilated, you know, window units, AC, those type of things that you know, that you need to know about. Each site visit creates opportunity to interview the index. So here's your follow-up interview. That will let you know if he's telling you the same thing that he told you prior to. Pertinent details about the room size, ventilation, airflow pattern. Again, that's involved in the home visit. These factors should be considered to extend to the content of how often and along the contacts have been in each setting. Okay. The field investigation, healthcare workers should remember to follow the infection control precaution while visiting. Okay, there we are again with the N95 mask. Making sure that that personal protective equipment is with you. Not taking chances that I'm going to run in here only for about 5 minutes and I left it, but I don't want to drive 10 minutes back to the clinic. Okay, but you're putting yourself at a risk. Okay, have that person come step outside that door and DOT them outside their home before you put yourself in a situation. Another critical consideration during, again, we talked about that safety. Take another person with you sometimes. If you have borrow someone from another program, if they can go with you and say, hey, I got this guy on the east side of town that I may need you to go out with me in the first couple of visits. When I started out, we did partnership. I had a partner, and we made visits as a team. And then until that person, and then we separated for a while. But teamwork, you have another set of eyes. If you don't have that teamwork, then you have to really consider researching this for this presentation. I pulled some information down from North Carolina Department of Public Health, and they have a very good field investigation documents, and so that was very useful about their safety, and I give them credit for that. Another critical consideration, you have to look at HIPAA, maintaining confidentiality. Okay, it is very challenging, but most cases or most patients, if the information is leaked, it's leaked by them, but they'll blame it on anyone, everyone. That you're spreading my business, or you're coming by here and they know who you are. Well, if I'm responsible for that homeless shelter, and I've been going there 5 years, and now I go there and I have to give you your medicine, and they see me talking to you one-on-one every day, I'm not breaking confidentiality. Everybody there know who I am. Especially if you work in small towns or you're the only one in that region or area, everybody know who that is. Especially if you work in STD, everybody know the STD guy, or the STD man, or the TB man. But that doesn't say that everybody I speak to has TB. But I didn't break confidentiality just because I'm speaking to you. So you might have to put that person in the car, drive them around the corner, give them their DOT, drop them off somewhere else, meet them at a certain location. So if you think that will stop or build that rapport or that compliance with that person, do what it takes. You know, meet them two corners down the road at a store and say, okay, here's your meds, here goes soda, bring the water with you, and boom, we're through. Constant attention is required to maintaining confidentiality. Sometimes when we build a rapport, we get in a habit of starting talking. You know, they want to be your friend. You have anybody else on this side of town? Then we open up a little bit. But you have to understand that confidentiality, we just can't really give information out. Have you found all my contacts? Have they been okay? We're constantly pursuing everyone that you gave me. Is there anybody else? Okay, so they're caring for those individuals, but then we can't give them everything. We cannot go back and say, well, we tested Johnny and we tested John and we tested Mary and they're fine. Then that person's also looking at, okay, I know Mary had a cough 2 months ago. Well, that's not her. Who else gave this to me? So understanding what they ask you could be, they're trying to determine where they got it from, or they could be determining other things. So in review, source case investigation. A source case investigation seeks the source of recent TB infection, perhaps newly diagnosed TB. TB disease in children aged less than 5 years old typically indicate that that is an infection that must be recent, because that 5-year-old hasn't lived that long, of course, 5 years old or less. Again, it goes back to where has this child been? Children do not routinely give TB to other children. So don't be looking for another child to find as their source. You look for an adult. Now who that adult may be could be right there underneath your nose, or it could be somebody that they're concealing. It could be that lady who has a home daycare that no one knows about. And now they're afraid DHR or DHS will be involved in shutting them down. So be aware of that also. For this reason, it's essential that public health event. Young children usually do not, again, like I stated, I got a little ahead of myself there, infect other people because of exposure to them. Site visits are important to the interview. They go along with the interview. It should be made, this is a review. It goes back, the interview should take place in less than 3 days of initial interview, the field investigation. Elicit additional contact information, especially helpful for finding children. If you notice this, it keep on coming back to children, and those are the ones that are missed a lot. We look for co-workers, we look for, but those children, grandchildren, great-grand, who, as you make that home visit, look for pictures. Look at the age of the pictures. They'll tell you if that's a recent picture or that's somebody been sitting on that shelf for 40 years. Who is this person? Again, if you bombard an individual with questions all at one time, they're going to shut down. But as you continue to go to that home, because the investigation is always continuing. If you're going to treat this person 6 to 9 months, every day you're investigating. Every visit in the home, you're asking something about where you've been, who these people are. So today may not be my day to ask about that portrait, but tomorrow, hey, who is this right here? Oh, that's my grandchild. That's my granddaughter. How often does she come over? And without thinking, they'll let them talk. They will tell you exactly, oh, they come over every now and then, or they come over, what would you consider every now and then? Every weekend. So now that's a missed contact we need to find. So again, leave that there for the day. Tomorrow, hey, you mentioned about your granddaughter yesterday. Where do they live? And you keep building that investigation. So lack of site visit has contributed to TB outbreaks. That's a nasty word, outbreak. But most outbreaks are, I wouldn't say that the investigation didn't do their part. It could be a part of it, but it could be where the person did not provide truthful information. Okay, but don't let it be that you just didn't do what you needed to do. So looking at the priority of contacts, again, this could be found in MMWR, or you can be found on the CDC website and look at the household contact, less than 5. Those are high risk. And it goes into the medium risk. Those greater than 5, less than 15. And then you have your low risk people. So if you hit your high risk contact people, again, order might not matter. But as long as you hit those high risk contacts, you'll be pretty much on the right path of making sure that you're capturing everyone. So this is going to end for the first session, and we'll come back with the special consideration, and that will involve the mass investigation portion of this presentation.
So I think we'll stop here and take a 15-minute break, and I hope to see you back shortly. Thank you, Carl.
You're welcome.
Welcome back to TB Case Investigations. The second segment is Special Considerations during Contact Investigations. I'd like to welcome back Carl Evans, from TB Program Manager from Public Health Area 2. And Carl?
Okay. Well, welcome back again. In this part of the presentation here, I want to address contact investigation that outside of the home, and these are large investigations. These are ones that we're going to look at that pulls everything together in the sense of the personnel, the resources that you may have to go multiple programs. You might have to use people from different organizations. If we cannot find the personnel in-house, meaning in the TB portion, you may have to ask people from other programs, and just to expose you to what we sometimes deal with in a large-scale investigations. And these are very difficult if we let it be. But if you have individuals who are task-oriented, or you find those individuals who know how to do, what they're best at doing, you rely on them to do what they do best. And you have someone who can keep data, that is their job. Someone who can draw blood and do it efficiently, that's their job. So let's look at these case investigations that we consider special consideration. So a contact investigation in a congruent setting. Now, a lot of this material that I have chosen today is coming directly out of the MMWR, and that is from December 2005. You'll be easily find that from CDC. So if you want to reference that and go back and look at that in that portion, if you do not have it, you can order it from CDC. So in those settings, we're going to look at schools, workplaces, prisons, jails, shelters, and places of worship. In a congruent setting, the concerns associated with congruent setting are a substantial number of contacts. And here again, over-testing is possible because we're dealing with those individuals that we know we want. We have concisely defined those individuals. We have made our visit to that workplace or that place, and we have identified who we want, but we always have to worry about the word well. Well, we consider those individuals who always suspected that you're leaving me out. I've been left out of this investigation. You didn't offer me a test. And that is that little chatter that we hear all the time. And those are the ones that, even though they might be small, but they can give you the bigger problems on down the line. And they'll keep chirping until they get someone attention, either through a media or some type of outlet, so their voice could be heard. So let's look at the congregate setting. We have a substantial number of contacts, incomplete information regarding names and location, because in that workplace or in those settings, you might not know all their names. You just know I attend services at 9:30 and I sit on a pew with other 10 people. Or I'm singing in the choir, I don't know all their names. So you can see how that can be very difficult. Incomplete data for determining priorities. Okay? The difficulty in maintaining confidentiality. So these are the things that we're concerned with when we're dealing with congregate settings. Also, we have collaboration with officials, administrators who are unfamiliar with TB. Again, we go back to that layperson, understanding the difference between disease and infection, understanding the severity that once you have the disease, how it's transmitted, and depending upon if that person is listening to you, how they're going to try to get their PR people on top of it and get it out where it doesn't affect their bottom line, the money, the dollars. So, legal implications and media coverage. Okay. Possible situation for news coverage. Again, that may be that person who's chirping in the wind, and finally they get the attention of the local media, and what we have to contend with is certain investigations have the potential sensation for news. Again, these people want to present what people want to hear. It may not be anything to you and I, being that we're in the health department, but to them it's significant to make the 6 o'clock news. Okay, Factory XYP has an outbreak of TB. Now the public is alarmed at Factory XYZ, and then from there we only could be treating one person. And so that you can see why Factory XYZ is saying, look, I have gotten a bad rep here. Hurry up with this investigation and get out. And they show you the door. But we want to make sure we don't miss anyone. So examples include involving numerous contacts, especially children. So that could be that daycare. That could be that child development center, or academy, or school. So here we have to look at, and sometimes it's not bad to have the media on your side. Okay, you can't look at it always as a negative thing. Look at it as a positive, because you're reaching those individuals who may be missed. If you don't, no one will tell you about those students that transferred, or been missing school on a regular basis. Here you have the opportunity to say, hey, the news is doing us a job. They're doing a good job of getting this information out, and now we can capture everyone we need. So, occurring in public settings, occurring in workplaces, associated with TB fatalities, and here recently, not recently, but some time ago, that brought very good news coverage to our colleges and universities. Years ago, we had an individual to die of TB, and that brought a lot of changes in Alabama with our college and university testing. So again, all the news media is not bad, but you have to provide accurate information, but you don't have to give them confidential information. So associated with drugs and resistant TB. So let's look at schools. Daycares, elementary, high school, colleges, and university. So early collaboration with schools officials and community members are recommended, and they are essential. Really, what your homework is to go to those schools, meet with the partners who are the principal, the board of directors, someone that is the schoolmaster and say, look, this is what we have. This is what we intend to do. And with your assistance, we can come up with a PR statement that we both are working together to try to maintain this situation, and we'll get out of here as soon as possible. And that may involve, with the schools, again, you need consent. These things are not going to happen as fast as you going into someone's home and say, hey, I'm Carl, I'm from the health department. I need to offer everybody testing in the home, and then within a period of time, maybe a day or so, you come back and test everybody in the house. Here, when you issue that consent form, they have to take it home, or we give it to a town hall meeting, give it to the parents, they sign it, we look at it, and then we look at refusals, and we look at, so we have to, it's not going to happen in a time frame that you think like 1, 2, 3 days. This may go on, just to get the consent form back, be a week. So we have to do a assent and disclosure of information which are more complex with minors because they cannot sign for themselves. So the site visits should be conducted to check indoor space. Again, you have to make a visit to the school or the colleges or wherever you're going. Look at that room. Look at the ventilation system. Look at the time and duration that person spent there. So all these things continue to come back into play if you know the procedure of the investigations. Make that visit. Look at the ventilation system. Look at the indoor space and the duration of time, knowing the virulence of this disease, virulence of this TB germ. Okay. So if the person is spewing out numerous AFBs, then you can believe that this germ could have affected more people. If they're spewing out smear negative, culture positive, then your number rate may be low, but you still have to go there and conduct that investigation. So evaluating and following up of children less than 5 years of age is always a sign of high priority. If you were with us last hour, you saw the slide for that. And the contacts should be received full diagnostic eval, including a chest x-ray. So not only are you testing using the M.tb or IGRA, depending on what age of that child you can use the IGRA for, but you also offering that chest x-ray, either referring them or bringing in the technician to do that x-ray on site. And many times we'll go into that that school or that facility and have that x-ray capability on site. So if you have technicians that travel or mobile x-ray, that is great to have. Great to have. Instead of sending 40 referrals out, we have the capability here to get that x-ray technician with a mobile x-ray and go to that school and perform those chest x-rays on site with the parents being there. If not, the parents consent to have the x-ray. So that's how you evaluate those children, with a skin test or M.tb method or IGRA, and also radiographic of chest x-ray. TST less than equal to 5 millimeters of duration, and last exposure is greater than 8 weeks. LTBI treatment is recommended after TB disease is excluded. So we have to exclude the disease. So this child does not have disease, but they have a positive skin test at greater than 5, because we know the cutoff point for exposure from someone, if that millimeter reading is 5 or greater, that means that we believe that TB germ is in the body. So the exposure is greater than 8 weeks, so we're going to recommend LTBI. The drug of choice for prevention is isoniazid, but it's also, depending upon the TB physician recommendation, if we're looking at what the index case, you have to look at if that person is resistant to isoniazid at that same time. So you don't want to put a child or someone on isoniazid and that the index case or source case is resistant, and that's not doing the job you intended for it to do. So evaluation and follow-up of children greater than 5 years of age. The second TST, we come back. Not only do we do one test for those who are TST negative or IGRA tested negative, we come back 10 to 12 weeks later, and we do the second round of testing. And here we're trying to see if that germ now is present in that person's body. And by doing that, we look at the decision to reconsider to treat. Negative TST meaning we treatment is discontinued. And then positive meaning we continue with that same treatment. Okay? So that we looked at schools, but we're going to look at universities in the workplace also. So you're going to see universities in two locations, schools and workplaces, because we're addressing the student and we're addressing the faculty. In the school setting for a university, it plays out a little different from a middle school or elementary or high school, meaning consent. Now you have a person who consent for themselves. So it's not a slow process. You can go there, you meet with the dean, you meet with the provost, or you meet with the president, or whoever you need, the players of that university. You get your PR statement together, you go in, you find your resources, how many people you need to do the testing. You go in, you locate a site on the university testing, you announce it, and you go in and test, and you get off the campus, and then you go back to read those skin tests, and you make sure that there's follow-up. People who are missed, you have to ensure that they are directed to come to the health department or another scheduling date. Sometimes the student will not come to you. You ensure that you can continue to go to the student. If you get the school on your side, or you get the administrators to determine, hey, if you don't get tested, again, it's not us to make those decisions, it's to the university or whoever. If you get those individuals who are determined to say, hey, you don't get this done, we'll withhold this and withhold that, that's great. That helps us out a lot because we know eventually we'll get those students. But if there's no stiff penalty or anything, we have to keep working with that student. If it's someone that you really believe that will continue to, again, we do benefit, but we do believe everybody who's a contact, direct, close contact, need a testing. But sometimes you have to say, okay, well, I've given you every opportunity, and now I'm just going to back off. But let it be known to that person that at any time they wish to have that test, you come on back in and we'll take it. We'll do it for them. So now we're going to move on to the workplace. We're going to look at those places where the private industry, the hospital, university, military installations. All four of these have different aspects of difficulty, and military installation will be the one with the most difficulty of accessing, because you're going to need a partner on that other side to do your work for you if it's involving a military member. So let's look at workplaces in the sense of duration and proximity of exposure can be greater than those of others. So if you're working in a facility and they have a line, when you go to that workplace and that production manager or that person showing you around, you have to be sure that you're asking the right question, because your investigation is being dictated to you by them. But you don't need them. I mean, really, not saying you don't need, but you want to be sure that you're capturing the right people. Just by going in and testing them, you might not be getting the right people. Okay? But you want to ensure that if they're telling you line A, B, and C is where this person worked, then you have to look at, okay, is there a possibility they're only feeding me to go ahead and do this test and get out of here? So you might go back to that individual again. What lines are you working? What time are you working? Have you worked other lines? How do they move you around? Are you standing by the same person every time? And they'll tell you more than production manager or assembly person, because they might just say, okay, give them these two lines, and then they'll be out of here, and the possibility you're not testing the right people. Okay? So, but you have to have somebody willing to go in those places. We do have workplaces that some people do not want to go in workplaces, but you have to pull up your pants and go in these workplaces that do manufacturing, or they do assembly, or whatever it is they're doing. You have to go in there and find out, okay, again, the ventilation, the spacing, where the break rooms are, where the bathrooms are. You have to find all that information out, because that case is using the bathroom, and that case is going to the break room. If he's not in the break room, or she's not in the break room, where's she going? Out to a car at break time? Who she's riding to work with? You have to ensure that you continue to monitor every aspect of that workplace, in the sense of who's out on vacation, who's out on maternity leave, who could be possibly out for anything. Because out of sight could be out of mind in a lot of these workplaces, and who's been temporary workers, for example, are mostly exempt from a lot of these things because they don't remember that he only worked there 3 days. Okay, so you want to also go to, if there's an outside temp service, you may have to go to that temp service to acquire that information, because the workplace may not have the temp service address and all that stuff. So let's get back. Details together from the index patient during the initial interview include employment hours, working condition, workplace contacts. Occasional customers or workplace should be designated as low priority. Okay, occasionally they will be. They'll be on that outside layer of the concentric circle. But routinely, that workplace is in the second layer outside of home. The occasional workers, excuse me, could be on that outside edge, depending upon if they're temp workers or depending upon where they are. I mean, what job they're doing. If they're a landscaper and they're outside working, that may not be someone you need to concentrate on unless they're riding with that individual to work. Excuse me. So, moving on to prison and jails. Let me go back to military installations. We didn't address that specifically. But on military installations, that falls under federal regulations. So as a state, you will have to meet the counterpart on the other side. If it's a military personnel, you will have to, again, share that information. Again, that's not considered breaking confidentiality when you have a counterpart, like sending interjurisdictional. But you must let that person know that anything, if the military person is a TB case, the dependents you can work. But that installation, that military person will be followed by community health in the military. But the dependents, they now with TRICARE and with all the outside facilities, they come off post and they can be treated at the local health department. We have provided services to several dependents through the health department, and sometimes you have to get assistance from the commander or from that individual soldier's unit, because you have circumstances that may arise where the patient becomes difficult, don't want to be observed DOT, or the military member himself may be the stop gate where, hey, I don't want you dealing with my wife anymore, I want to do this, then you have to have that liaison on the other side to say, hey, you have to do what these people are asking you to do. But in the military, just remember that you need federal regulations, that even on other installations like Native Americans reservations, you have to have that same partnership, because it's a different entity over there. Prisons and jail. Detention, group homes, centers, local jails, and prison. Again, each one of these have different diversities. Dealing with the detention group home is much different than dealing with DOC, prisons. Dealing with the number of inmates or personnel. Local jails, depending upon the size of the jail. You might have a county jail with only one nurse, and that could be a part-time nurse, versus a metropolitan area that may have a staff of nurses with, many more inmates. And so, again, establishing a rapport with those nurses or medical staff is important, because if you don't have that rapport and they don't want to work with you, then that is a very difficult situation when you're trying to move inmates in and out of jails and prisons to come to the health department, or we get into there to do our job. So establishing a pre-existing formal collaboration between correction and public health official. We do have a liaison with the ADPH and DOC here in Alabama, Mr. Morgan, and he is very useful in ensuring that our protocol is followed in DOC, because just because that inmate is there today doesn't mean that inmate would be there tomorrow. It could be a person in the free world, and now that becomes our patient in the free world. So we want a continuation of care that's in the DOC and also on our end. So trace high priority contacts are to be transferred, released, or paroled before medical evaluation for TB. Also, we have to look at LTBI. We have a TB discharge plan. Before that person is released or paroled or whatever, we like to know if that person is still on LTBI treatment, so we can continue that care or provide that person another opportunity to continue that care if they wish to continue, and they can get their medication through the health department free of charge. Low completion rates are anticipated unless follow-through supervision can be arranged or released for parole inmates. And we do see that quite often where inmate released, they don't want any more dealing with anyone, I want to be my own person again, I don't have any connection to you, and we lose that person. And that person could be in month number 5 and need one more bottle, or month number 8 and need one more bottle, depending upon what recommendation you're following. And we hate to lose that person. But if we can spend time and try to educate that person to say, look, this is going to benefit you. If you just take these last remaining tablets, we're through with you. And that may help. But if you feel like that person doesn't want any help, then you have to just move on. So correction facilities, when you go into a large-scale facility like that, again, you must meet with the warden. You must meet with the medical staff. If it's a outside assigned medical staff that's running the prison rather than a in-hire medical staff, making sure you meet with the partners for that organization. And inside the prison or correction facility, you have to review the medical records. So making sure that all the records are present. Making sure that before you go in, sometimes you may not have the opportunity to read every medical record to find out if that person had a prior positive skin test. Sometimes you may have to test and then review the medical records. Or if you have the time to review the medical records, make sure you have adequate staff to find out if there's no if there is no documentation of a TB skin test that is positive, you repeat that test. That's the best recommendation we can give. So then it's documented, and then you can move on and provide treatment. But having that partnership with DOC or the medical staff, it helps. If there's a confrontation, that just slows things down. We ask that we'll continue to have partnership with that organization and having their staff available, because most of the time they think we're going to bring all the personnel in, and sometimes we may need their assistance. And okay, we need 2 of your nurses, or we need, because in a correction facility, you have people who may be on dialysis. You may have people who only have one spot where they know they can get blood, and you might have that special nurse there who know how to get that blood. And so having those people readily available will benefit you in your testing. And we found that out some while ago when we had correction facility up here. Shelters. Probably this group of population or this location will cause you to sometimes pull your hair out, and when you're testing shelters, and because your time schedules can be really determining upon when when these clients are coming in. Okay, so if you have an in-house population or a transit population, meaning that the transit population, they only open their doors to the transit at 7 p.m. and they are out of there by 7 a.m. Well, we think our work hours are 8 to 5. No, you might be there at 12 midnight to capture these individuals and be there or before they get up and walk out, because they can walk out any time. So again, people you test today may not be the same one coming back 48 to 72 hours later, or if you're able to find them again. So in-house population, they're there, they're going through a program, they're trying to either, again, drug alcohol program, or they might be getting their GED, whatever it may be, is different. So the challenges include locating the patient in contacts if mobile, episodic incarceration, migration from one jurisdiction to another. So again, checking the shelters, checking the jail, looking at the blotter report, looking at the migration of what these. Okay, if Johnny's not here in Huntsville, where other location does he travel? Birmingham, what shelter? And then you have to find that shelter, call that other manager in that other area, and send that paperwork down. So again, 8 to 5 may not. 8 to 5 is just your time, but 8 to 5 is not does not capture other people's time. So you might be there at 2 o'clock in the morning trying to catch these people before they get out and walk out that shelter. And that's when we call on. If we don't have the assistance from other staff, we might ask the STD people. We'll ask someone else. Are you available? And so that's some of the things that we do. Here, in a homeless shelter, you have people from all diversities. So they might have pre-existing medical condition. Site visit and interviews are crucial. Again, you have to make those site visits. You want to see what's the spacing. Does each individual person have their own little 6x6 room, or are they have a little mat on the floor and they have like 12 inches between each other? Okay, do they have one big box fan at one door that's shooting that bringing air, drawing air in and out the other door, or is it ventilated by air conditioner or AC units? So site visit interviews are crucial. Interview could consist of the personnel that's assigned to check these individuals in, or it can be an interview with other residents. Because eventually you work in that location, so many people stay in these residencies year after year, and they know who you are. Who are you looking for? Oh, he doesn't come over here anymore. He's over there at the other one. And so those are things. Places of worship. This is where really confidentiality is. There's a mixture here with confidentiality, because depending upon how large the church, small churches, for example, everyone knows everyone, especially as a family church. One member is out for 2 weeks, they're missed. Everybody's up at the hospital visiting. So when we say, Pastor, we're here and we want to provide testing for the congregation, well, we want to provide testing for these individuals, they already know, oh, that's brother so-and-so. Here again, we can't disclose who that is, but we're saying they already know. Okay? So brother so-and-so is like, oh yeah, no problem. Now in that mega church, you have a congregation of 5,000 people for a service. That's massive. So again, you have to look at, okay, you sing in the number 13 choir? How many members of that choir? I just sit on a pew that's in the 191st row A, and I don't know who sits by me, and you'll never get those individuals. I mean, I wouldn't even consider looking at a massive mega church unless you just know specifically this person runs the nursery, or they know what the specific task they do. But if they're just a member of the congregation, they change seats everywhere in the church, it's going to be hard to look at that investigation saying we need to go to that mega church and test. So interview and test contacts on site is optimum. Alternative is evaluation at the health department for additional personnel, extended hours. So if they don't want you at their church, you have to make accommodations at the health department. They have to come to you, or you have to say, who's a primary member of the church? Can we meet at your home, or can we come out here on Saturday and meet in the fellowship hall? Because again, it all contingent upon the pastor or whoever the lead person is at that church. The last resort, notify contacts in writing. This is going to be not very difficult, but this is going to take a lot of time. Addressing a letter, mailing it out, bringing it back in, looking at it. So we want to go to them most of the time. Go to the site, provide testing. Congregate setting, design priorities, site-specific, customized algorithm required for each section. Again, this information can be acquired through the MMWR, Volume 54, 2005. So if we went too fast on this one, or you think that you want to go back, you can always go back and look at this in depth. So, congregate setting, designing priorities, environmental factors that modify transmission, susceptibility of contacts. Again, how virulent is this bacteria, the duration of time, and the environment that you're in. So, as a review, TB transmission. The probability that TB will be transmitted depends on how infectious the person is, the environment that you spend with that person, the length of exposure, and how tough or how virulent is this germ. Okay? The best way to stop transmission is to isolate the infectious person, provide effective treatment to the infected person as soon as possible. Okay? So we thank you for tuning in today.
Is there any questions or any comments from people in the audience?
You were talking earlier about parental consent in the schools.
Yes,
what
ma'am.
age? At what age do you require?
14 is the age of cutoff, pretty much. Because high school students can pretty much make that consent. But now, again, if they want to consult with their parents, sometimes we find parents still come up there to the school. But 14 is that age. Yes, ma'am.
And just a comment along those lines, since we've all participated in investigations, if we have an investigation in a setting such as a daycare, which actually Carl and I participated in one, I think a couple of years ago now, it's very important that you coordinate with parents. And I find that if you educate the parents, as the DISs do, and coordinate with them, that you very likely will have a high participation rate. And parents, caregivers are generally very, very concerned about the children. Then you have to balance that with any concerns that might come in if the news media contacts you. Well, you're doing TB testing at this daycare. Why do we need to do that? Are all these children at risk? Do we, have an outbreak in the community? So I think you have to answer those questions. But again, it really gets back to, in investigations, as Carl has so appropriately pointed out, just educate, educate, educate.
And adding to that, we frequently, he mentioned using the media as to help our investigation. Oftentimes when we have a high-profile case or something that we think could leak to the media, we will try to head that off at the pass with a press release. If we have a college or university or a well-known workplace, a large assembly plant of some kind, there does seem to be some issues with people getting upset because they're not included in the testing. But we call those people the worried whale, people who may not necessarily need to be screened, but they think they need to be screened. So using the media to educate those people is often a very valuable tool in our toolbox.
Question for our social work staff that they don't typically get the TB referrals and going in the home. I know that you mentioned about talking with the staff and getting as much information as possible, but what are some of the safety for their personal protection? What are some of the steps of the safety issues that you would suggest?
Field safety, making sure again, we rely on GPS and rely on, but just doing your homework in the sense of knowing how to get in and out of the area, how to park, how is it to introduce yourself. If you don't feel safe, making sure you have your ID badge on. If you don't feel safe, always get out, come back with either having that patient come in. Anytime you do not feel safe in the field, go back and report it to a supervisor. And either that supervisor will either make a decision that, hey, you need to send out another partner with you, or we'll invite that person, or the manager himself will go out with that individual and to assess that concern. But field safety is a crucial part of the investigation because we don't want anyone to get hurt, especially the worker. So by doing that, we need to invest more time with the staff on field safety, because there's no specific SOP as I know of field safety, but you have to look at, before you can build that rapport, you have to know who you're dealing with. Is this person able to comprehend what I'm basically trying to get over, or getting a family member to go out there with you, and they might tell you a little bit more about this person.
I think I'm basically talking more about the worker being concerned about contracting.
Personal respiration.
Oh, right.
One of the things that the social work staff really need to work with the TB staff in that area, the TB staff can help them understand the level of infectiousness of different people. Some people may be highly contagious, some people may not be contagious at all. So working closely with the TB staff in the area is the most important thing. There are a couple of different ways that you can protect yourself in that you can wear an N95 mask. You can also have the patient themselves to wear a surgical mask. The droplet nuclei that are expelled into the air are large enough to be caught in a tissue. So if they're coughing, if they cover their cough or have a surgical mask on, then that will catch that bacteria. But if you are going into a setting where they've already been coughing, like in their home, and those germs are likely floating around in the air already, then that person, the worker, would want to wear the N95 mask. General rule of thumb is the well person wears the N95 mask, the sick person wears the surgical mask. Another thing is if you can conduct your investigation outdoors. Transmission is almost impossible if you're outside because open ventilation and ultraviolet light, sunlight kills the bacteria. So with our staff, even, we know who's infectious, and we will have our interviews in locations that we know transmission would be less likely to occur.
Thank you.
We have an email question.
Yes, we do have an email question from David. He said, are there any good examples of high-profile TB outbreaks in Alabama?
Actually, we have had several press releases in the previous year. The last couple of years, we had a college student here in Montgomery that had active TB, and that did involve a large screening of people that were in the dorm with that student as well as the classmates. We had a TB case at the Mercedes-Benz plant in Tuscaloosa County, and we tested a couple of hundred people there. In the Department of Corrections, we've had several cases this year. Those are the three main high-profile cases that I can think of off the top of my head. We've had cases that worked in various restaurants, and that's always kind of a touchy subject because people don't understand that TB can't be spread through food. So, if we have a TB case that works in a fast food restaurant, the length of time that a customer would be inside there is not really conducive to transmission. So our efforts would be focused more on employees, and sometimes that can cause a little bit of concern in the community because I go to that restaurant chain once or twice a week, and you're not offering me testing. Well, how long are you in there? 20 minutes, and the person that's sick may or may not have been in there when you were there. And we would focus more on the employees that worked with that sick person. And if there was a high number of those people that were infected, then we may expand from there. Anything else? Well, I appreciate you joining us for our two-part series. It is my understanding this will be on demand. I'm not sure the date of that yet, hopefully after the first of the year. And thank you for tuning in.
Thank you.